Can you help educate me and then in turn my parents and the audience on how ozone therapy via the colonic, via the sauna that I just did, via the ozone infusion into my blood, the ubu or obo?
Ibu.
Can you help me and us understand how that complements the insulin potentiated chemotherapy? My name is Noah, and I'm in the fight of my life against a rare stage 3 appendix cancer that I had diagnosed back in December after a month of excruciating stomach pain. So sauna first today. Ozone sauna today. Oh yeah, I tried that yesterday. That stuff tastes like caca.
Yeah, it's really salty. Yeah, he said it's a little uncomfortable. There you go.
Thanks.
You're welcome. And then once that's gone, just come find me.
Yeah. When you've got an opening, find me.
Okay, I'll ask.
Okay.
So
Make a copy.
I'm all done.
Oh, nice. You can lower it. Okay. All right, we're gonna go down the hall that way.
You want to come and see? Mm-hmm. Is there a seat in there?
Yes.
That makes sense.
Yeah, we lowered it for you too, because she said you're tall.
Oh, I'm tall.
Tall, sweetheart. Don't let anybody tell you different.
I won't.
All right. All right, that should be good.
Thank you, Caitlin.
Of course.
I think.
Because I don't want to screw up.
All right, guys. So this is the sauna ozone therapy. It just feels like, well, it feels like a sauna, I guess. Everything they do here is ozone. They do ozone in the colonic. They do ozone blood transfusions, effectively cleaning out your blood, pulling blood out, putting O3 ozone in, and now we're doing ozone for my skin, and I'm assuming I'm just sweating and detoxing. It seems like between your chemotherapy treatments, detoxing is the name of the game. This feels pretty nice. I'm just gonna rest and take it in. I do know that one of the things my specific cancer does not do well with is heat. We learned this from the RGCC blood tests, which specifically gives us all the information we could possibly want to know about my specific cancer. Luckily, as a counterpoint to my cancer being good at detoxification, my cancer really struggles with high heat, specifically, and that's great. I do think this high heat is also part of that thinking process here at the Nevada Center, or at least I speculate.
Okay, we're gonna get you out.
Thank you. So my butt cheeks are just hot to the touch.
Yeah,
of this thing.
the air comes in through the bottom right under the seat.
Maybe like 2 towels next time.
Yeah, we can do that. No
Feel my
problem.
butt cheeks like burning.
And then I'm gonna leave this towel for you to dry off with.
Cool.
And everything's turned off. So once you're done, feel free to walk out.
Nice.
We have another drink for you up at the front.
Thank you. Do you mind turning that fan off?
Yes.
Amazing. Or
Great.
off. Is it off? Oh, it's this thing that I'm hearing. Forgive
Oh.
me.
I'm gonna turn this off, Jim.
Oh yeah. Alright guys, the first ozone sauna went great. It actually felt cozy and good. The only thing I'm noticing, and I'm excited to get up, is that my butt cheeks are burning. I suppose I don't have as much meat on there as I used to.
So the main thing that I wanted to do today is just see how you're doing. Your blood tests look all good, so you're holding up that way.
When you say they look all good, can you be more specific?
Well, the CBC and the chem panel, your liver's good, you're not getting anemic, your white cells aren't dropping out.
Good.
These are the kind of complications you could see with chemo.
I see. Okay.
You've had what, like 2 now?
3.
You've had 3? Okay, so you got, 3 more to go.
Yes, sir.
How are you feeling?
Fatigue. That's the only negative side effect that I think can't be, I guess I would say, psychosomatic. Like it has to be a real thing.
No, it wears you out.
Yeah,
It just wears you out.
It's I track my sleep with Whoop, and so I'm able to, I know my sleeping patterns. I know exactly how I behave with sleep, and I'm sleeping 8 to 10 hours a day between sleep and nap,
Yeah.
which is 30-40% more than normal. So
Well,
I
you
feel,
need your sleep.
yeah, I
This
said,
is a challenge.
yes, sir.
What's up with your eye, by the way?
I just thought I'd pick up a sigh
Is that what it is?
to make all of
you
this
put
more
compresses
dramatic.
on there and everything?
Not yet, no.
Well, you should put compresses on it.
Okay.
Okay.
But no, other than fatigue and a little bit of underlying nausea that seems to have started these last few days, just a small baseline of nausea, and some digestive unpredictability, I think I've been tolerating it all pretty well. I certainly love your staff here, and I really like
Yeah.
being here.
Yeah, good.
Yeah.
Yeah. That's a great crew. Yeah,
Oh, it's
for
such a
sure,
great
yeah.
crew.
Yeah.
Yeah.
Any questions? Anything like that?
I think what's popping into my head are two things. One, when it comes to the effectiveness of IPT relative to its comparison to traditional chemotherapy, and then the insulin angle, how big a difference does it make for the chemo agent at that lower dose when complementary with your insulin? How big a difference does it make how close you get to the floor of your blood sugar tolerance, let's say? Like, how hypoglycemic is it good to get? Because that's been an interesting battle. The first
Yeah.
day I came in fasted, and I'll end my little rant here, but the first day I came in 36 hours fasted, 15 units got me to a pretty sweaty, messy place quick. But I ate a normal diet the whole day leading up to the second time I did it, and it seemed like they couldn't get my blood sugar down no matter how much they gave me. And then I went fasted again, and then it was once again effective.
Yeah. So normally this doesn't happen. This normally they'll dial you in right away. I think it has to do with the fact that you're like way more fit than most of the people. You're aerobically fit than most of the people we deal with, and probably there's like such a low incidence of insulin resistance.
Yeah.
And I think, one of the lab tests you were showing me some ketones, and I'm thinking that you're showing me some ketones, and that might have played a role in it. I'm not sure. Lucy and I were, discussing it, trying to figure out what's up with this guy.
Yeah.
But she's finally got you dialed in, I think.
I think 20
Yeah,
worked out
good.
pretty well.
Let me see.
I find myself thinking when I'm doing it, I want this to be as effective as possible.
My general thinking is the lower the better.
So do you think we should push this next time to 23
If
units?
you can tolerate it, and I don't want you to, get to the point you get really whacked out, but
Like, how do you know? That's the interesting thing about this, is like, because in my head I'm like, man, if 3 or 4 more units would push me 3 or 4 more percentage points closer to surviving my cancer, push me closer
I'm thinking you're absolutely right.
dude, I love it.
So insulin dose,
Was 20 last
so
time.
20 plus 5 plus 5 plus 5 plus 10.
That was
Well,
when
that
he
was the
wasn't
second
fasting.
time.
That was the second time.
When I didn't fast. This last time at 36 hours fasted.
Oh, I see.
We would-
that would do it.
Yeah.
And then the first time she gave you 15, and did you drop then?
I did, but
Yeah.
it's hard for me to understand if I'm dropping far enough. Am I being stubborn?
How long does she keep you down there
30
before
40,
she
30,
brings you out?
30 to 40 minutes.
Really?
Yeah.
She's tough.
Yeah, no, he was dripping sweat.
Oh,
His hands and forearm went cold.
yeah. So there's how low does it get, and there's also how long is it low.
Oh, okay.
Well, lots of times we don't keep people down there 5 to 10 minutes.
Oh, no, I was down. I've been down there at least 40 to 50 minutes.
Okay,
every
so
time.
that's good. That's potentiating the whole deal.
fantastic.
Yeah.
So we're probably doing it right.
Yeah, you're doing it right.
Amen.
So to pivot on that question, how does this therapy compare to traditional chemo?
There's no head-to-head
Right.
studies out there, so to speak. So all I can tell you is my own anecdotal experience. And I think it's infinitely better
Okay.
in the sense that, look at him. If he were getting conventional chemo, guy'd be a basket case. So in that sense, it's a lot better. I just cannot warrant in my head doing that to a person. Now, again, you're not my typical guy. My typical person is in their 60s and they eat donuts all day long and they're in horrible shape.
Yeah.
But so you're not typical in that sense, but the longer we can keep you down there, the better. And if I take the typical cancer patient and do what those guys do, the conventional guys do, it's going to be bad.
Yeah.
It's just going to be bad. And I get really good results. And I guess the only thing I could tell you is I get a lot of the conventional failures, and I do okay. So that kind of speaks that I'm at least as good as what they do.
Sure.
I think my cancer kill is every bit as good as what they do. I have no proof of that, but I'm pretty sure just from observation and the way patients have done.
As far as coming in and then finding remission post-treatment long term.
So you're a case in point. You had one node or something, if I recall.
6.
You had 6 nodes, and you had some unclear margins.
Correct.
Yeah, so I'll see that a lot with breast cancer patients. And they'll tell the breast cancer patient, I want you to get radiation and or chemo afterwards, just to, quote, be sure. And but they'll come to me, and we won't do the radiation, and I'll just do the 3-week protocol like I'm doing with you. And I have people that are 10, 15 years out, no problem.
How long before
And their margins were not clear, and they had a positive node.
How long, thank you for sharing that. How long post-treatment might you think anecdotally it can be expected, if this is working, to show some results or some potential progress that's a positive?
Well, it's, in monitoring you didn't have any positive markers, did you?
What do you mean by
Well, like there's a blood marker like CEA.
That wasn't positive.
Another one's called 19-9.
Wasn't positive.
Okay, so we don't have any markers to look at.
We just have the RGCC tumor cell count, and then
so we can do that.
the Natera or Signatera or some
Waiting
test
on
like
the
waiting.
Signatera.
We can do this, the circulating tumor cells. We can do that. At some point, we'll get a PET scan.
I have one scheduled for the second day I'm back.
Okay, all right. So and maybe we'll get another one a year from now. We're just gonna stay on your case for quite a while,
Yes,
just
sir.
to make sure we're on it and nothing's coming back.
Okay. Can you help educate me, and then in turn my parents and the audience, on how ozone therapy via the colonic, via the sauna that I just did, via the ozone infusion into my blood, the UBU or OBO?
EBU.
Can you help me and us understand how that complements the insulin potentiated chemotherapy? Because it seems to be in every facet of your protocol, minus, of course not literally every facet, but the fact that it's going through my blood, it's going into my rectum for the colonic, and now I've done the sauna, and then there's water. Can you help us understand why that's intended to go so together with the chemo?
Okay, so first of all, let me see, make sure I don't forget anything, but first of all, there is the antimicrobial aspect. Because when you're getting chemo, a large percentage, and I don't know how large it is, but it's something like 30-40% of the people that die from cancer die as a result of getting infections because their white cells are wiped out.
From traditional chemotherapy.
So that's a big potential problem. The white cells get wiped out, they get an infection, they got nothing to fight it, they're in crappy shape to start with, and that can do them in. So one of the things that's great about ozone therapy is it upregulates your immune system, especially your innate immune system. That's what they call the Th1 immune system. That's the one that stimulates natural killer cells, which are the parts of your immune system that kill cells. So you got 2 parts to your immune system. You got this one part called the innate, or Th1, and you got this other part called the Th2. The Th2 makes antibodies, but antibodies can't kill cells. They kill free-floating viruses and such like that, but they can't kill cells. So the only one that can kill cells is the Th1, and it amplifies Th1. So it's revving up your NK cells.
The ozone therapy.
The ozone therapy. So one of the you're doing really well. Your white count is excellent, but I will get people in here whose white counts are like super low, really bad.
Coming in.
No. While I'm treating them.
Got it.
And
What was his white count?
his was 5-6, but I'll get him down to like 1-2.
Yeah.
Wow. And I don't freak out because they just don't get infected. I've got a guy up right now in another state that I'm kind of working with remotely, and he's got leukemia, and his white count is been 1.2 with like 5 platelets for the last 2 years. He's on ozone therapy. He never has a problem. So go figure. That's just wild. So it prevents the infections. The other thing it does is it adds oxidant stress to cancer cells, but it does the exact opposite to healthy cells.
Why is that?
Because cancer cells can't process the electrons that I'm hitting them with the ozone therapy. They can't process that, but healthy cells thrive on that. So it's a question where it's going to render your cancer cells more vulnerable, while at the same time it makes your healthy cells less vulnerable to the chemotherapeutic agents, which are typically oxidizing agents.
Interesting. Do you have, thank you for explaining that, in your mind, is there a hierarchy for which forms of ozone therapy are the most potent? Would the blood be the natural?
Yeah, you want to go blood.
Yeah,
we can do it other ways, and we do. I mean, when you get to colonics, you're getting it that way. We do it through the saunas. That's getting it through your skin because you got dendritic cells in your skin. It's a little bit more immune enhancing.
What are dendritic cells?
Dendritic cells are the cells, they also call them antigen presenting cells. So when you have something in your body that's not supposed to be there, it could be a pollen molecule, it could be a medication, it could be a cancer cell. Your immune system is going to recognize that. And one of the ways it recognizes it is through the dendritic cells. The dendritic cells say, that's not natural around here. So they go grab the antigen and take it over to a Th1 or Th2 helper cell. And that sets about the whole cascade of immune events that ends up killing this thing, whatever it was that the dendritic cells found. So they're kind of the orchestrators of the whole deal. They start the whole deal going, and they're in they line where you think they'd be, in all the parts of your body that interface with the environment. So they're loading up in your GI tract, your respiratory tract. They'll load up on your GI tract, and they'll load up in your skin. That's where all the dendritics are.
Interesting.
So if I go ahead and give you an ozone sauna, it's going to go right through those dendritic cells and stimulate them. So that's why I use it for that.
Awesome. Okay.
It revs up your detoxification systems too.
Yeah.
Ozone's a potent rever up the detoxification systems, and if you give it rectally, it's going to go straight to your liver, and your liver's got to clean up all this junk. So I'm giving you some drugs that are toxic.
Right.
And they're killing cells, and that releases toxicity.
Sure.
So
is that called cancer cell
it's
death?
a die-off. It's a die-off reaction.
And that's a real thing?
Yeah, it's an absolutely real thing. It's such a real thing, you got to be careful if a person has certain cancers in certain bad places. You want to kill the cancer, but you don't want to kill it too fast.
Interesting.
Because it'll be a problem.
Because of the die-off.
And the die-off.
Does it come with obvious side effects and like fatigue and or nausea and or what?
You just got to be careful.
Okay.
In certain situations, you just got to know, and particularly brain cancers.
Gotcha.
You can't mess with a brain cancer.
Okay. What are your thoughts on exercise for me, to whatever capacity and to whatever extent, going on the second half of my treatment here, so the 3 more IPTs.
If I were you, I just go to sleep and take it easy.
Okay.
Yeah, you've been told
Take a few weeks off. It's all right.
Walks okay?
Yeah,
Are you going for a walk okay?
Yeah, just don't push yourself like you normally would. Don't do that.
Yes.
Wait till you're fully recovered, and that could be in 4 weeks, easy.
Really?
And then get back on schedule again. Yeah.
Okay. Doc, or Dad, Mom, are there any other questions or thoughts you specifically have relative to what we've been doing?
Two that I'm thinking about. How do you pick the dose of chemo when you're doing insulin potentiated compared to standard? And then I'm also just curious about hyperbarics versus ozone.
On how I pick the drugs, I have these books. I've now got a really cool AI program on my computer, which is like changing my world.
Yeah.
But I can plug into that, and I can find out what the conventional guys give.
Right.
What they give and what kind of doses they give. I give about 1/8 to 1/10 of that dose.
Wow.
So that's how I figure the dose.
1/8.
And you're thinking, from what you understand of insulin potentiated, is that 1/10 dose will be equivalent to?
Exactly. That's the whole idea.
Yeah.
Now, the guy that invented this, a Mexican by the name of Perez, invented it in the 50s, And he just by trial and error figured that little mix out. So that's what I was taught a couple decades ago, and that's what I do. About 1/8 to 1/10 the standard dose.
Wow. And to pivot to hyperbaric, we've heard mixed things.
Yeah.
Like hyperbaric is different than ozone, and
Well, hyperbaric, yeah. So there's mixed messages on that. There's the group that thinks hyperbaric provides an environment for cancer cells that's not conducive to their growth. There's another group that says, in certain cancer cells, they're going to feed off the oxygen you're giving them.
Right. That's exactly what we
they don't
wanted.
feed
Yeah.
off of the ozone.
Ozone's different. It's different form of oxygen. It's pure oxygen, of course, but it's a different form. It's an electron deficient form of oxygen. And so when it gets in a tissue, it's moving electrons. Like oxygen doesn't do that. Oxygen's got to get into your mitochondria to move the electrons.
Would you
It
say
can't
that,
move electrons on its own.
pardon the interruption, would you say that it's best with an active cancer to hold off on hyperbaric?
Yeah, I'm a little leery of hyperbaric in cancer just because I don't know. And, fact is, we do pretty good over here anyway. So
Yes.
I don't want to, do anything that I'm not pretty sure of.
Can you explain what chelation is if we have time? Because I think that's
Yes,
what I'm
'cause
about to go do.
I'm giving you a platin, right?
Yes, sir.
I'm giving you a platin drug. So platin drugs accumulate. And the bad news with the platin drug is they will accumulate even at the doses I use if I
Yeah.
do it enough. Because I'll get some people in here. I'll keep them here for 2 months. And
Wow.
I'll be doing them every 2 weeks, every 2 times a week for 2 months.
Oh, wow.
Yeah, and so these would be obviously some pretty bad cases. So those platin drugs, even though the doses I'm giving will accumulate, and when they accumulate, they start damaging your nerves. You get neuropathy. You get neuropathy of your feet, neuropathy of your hands.
Can you explain what neuropathy is?
Neuropathy is a toxicity involving the nerves. When it hits your feet, it normally hits the feet first because of the lack of circulation down
Sure.
there, and it'll cause numbness and tingling, sometimes painful numbness and tingling in the feet. Your balance will get off because you depend on your feet to give your brain feedback as to whether you're standing up straight or not.
Sure.
And you can also get it in your hands, so a numbness and a tingling kind of phenomenon in the hands and in the feet. And the problem with it is it's not always reversible. A lot of times it's not reversible.
I've heard stories of this.
Yeah. So this is a big deal.
The chelation.
Well, there's what we don't want you to get neuropathy.
Of course.
So there's a number of things we can do. One of them is chelation. Chelation will pull the platin drug out.
Is chelation just an IV infusion?
Yeah, it's just an IV. So I'm giving you the drug and letting it go in and get into the cancer cells and do all its nasty work. And then after it's done that, the day after, I'm going to pull the platin out of your tissues. So it doesn't tend to accumulate as much.
I see.
And the other thing that we'll do is we give you that pill, the nerve support pill.
Oh, I've not been doing a great job of taking that, if I'm being
You're
honest.
supposed to do a good job on that.
Okay, I'll do a better job.
But that's got It's got lipoic acid, acetylcarnitine arginate, and benfotiamine, which is a fat-soluble form of B1, which tends to prevent the platin from doing that.
Okay. Got it.
But that's how the chelation works. That's all it's doing. It's just pulling platin out.
Awesome.
What do you anticipate for follow-up?
Yeah.
Yeah, so basically looking at the CTCs, I told you about the SOT therapy,
Yes.
so I want to do that. And every time you do that, you get a CTC, you get a circulating tumor count.
How
And-
often?
Probably, well, no more than 3 months. Sometimes every 6 months, but certainly in 3 months. In 3 months, I want to do an SOT on you. And then we'll monitor it. 3 months after that, I'll get another CTC. Depending on what it looks like, I might wait another 6 months or another 3 months before I give you an SOT. It just depends on
And
what
that's a
happens.
one-day visit here?
Yeah, and you could actually do it yourself. It's a simple little infusion, but it's a one day thing.
One day
Yeah, it's a
thing.
quick little infusion. It takes us all of 20
Oh,
minutes.
you could ship it out of state and we could have it done?
I'll have to talk to the nurses about it,
Okay.
and see if it's something that would work that way.
I mean, I'm happy to make the drive.
Yeah, it's
a
not-
one-day drive.
Not that big a deal.
It's not that big a deal. Okay.
and then eventually a PET scan.
I have one literally the second day we're back
so
home.
maybe get another one in a year. Just kind of keep an eye on you.
Yes, sir.
Okay.
All right. I think we've tapped you out for questions for this
All
round.
right. Well, good.
I just
Awesome.
want to say thank you. Thank you so much for
Yeah.
helping me.
Okay, I'm happy to. These
Awesome.
cases are great cases for me because I get cases in here that are, pretty bad, pretty
Yeah.
difficult. You've probably seen some of them in there.
I think so.
Yeah. So
Yeah.
to get you in here is good.
Yeah. No, I mean, I think it's good to raise awareness that youngish, middle-aged, healthy, otherwise healthy people absolutely can end up in this circumstance.
It
And
can happen.
It can happen. And
We're
just to
seeing
know
it
that-
more and more, and colon CA in young people under the age of 40 is on the rise.
Yeah, that's
now,
what I
what's
hear.
up with that?
Your words of wisdom, though, to leverage anger if I want, but try not to fall into despair and sadness on our last visit has been good for me.
Good. All right.
I've been
good.
taking that to heart because I am prone to a little bit of despair from time to time. Like when I imagine not being around for my wife in a few years at this particular phase of our life, it's upsetting. So,
Oh, I can't imagine. I will tell you a story, and that is a colleague of mine who does anti-cancer treatment. Just dropped dead a couple of weeks ago,
sorry to hear that.
and I think about how he's sitting with patients that have cancer, some of them with stage 4 cancers, and he doesn't realize they're going to outlive him.
Yeah.
So we never know when that number's going to be called. So I could go tomorrow. Never know. So live your life like that. Be ready.
Be ready.
Be ready to go, and then forget it.
Be ready to go and then
Yeah,
forget it.
and don't necessarily think that you're going to go before somebody else, because it doesn't always work that way.
Sure. I'll be mindful of that.
Yeah. Just you got to get that attitude. It's a good attitude.
Yes, sir. Cool. I'll see you
All right, man.
next week.
Very good. Okay.
Thank you guys for letting us film.